and we're going to start getting ready for our next session. So this is a really exciting session. We're going to be doing the case competitions. As you know, all of our presenters have presented their cases already, and then they have been voted to be the most exciting cases, and they're here now to do a showdown. So I'm Jacqueline Tannis-Holland from the Cleveland Clinic, and I have Dr. Harry Nadeau from Westchester Medical Center, and then, of course, the panelists need no introduction, but Dr. Paul Saraja and Dr. Manos Berlakis. So we're going to go ahead and get started with our first presenter, and that will be Dr. Kyeeun Park, talking about right atrial compression from coronary artery perforation in a post-CABG patient managed with transhepatic pericardiocentesis. This sounds very scary.
All right, can you guys hear me? All right, awesome. All right, nice meeting you all. My name is Kyeeun Park. I'm current fellow at Memorial Healthcare System in Florida. So I'm really grateful and honored to be here. Thank you for this great opportunity. And I have pretty interesting and challenging case to present, so I hope you guys enjoy. So I have nothing to disclose. So we begin with 90-year-old male with a history of thoracic aortic aneurysm, coronary artery disease, who underwent CABG with saphenous venous graft to LAD about 20 to 25 years ago, who presented with chief complaint of chest pain, found to be STEMI. So we took him to the cath lab for further evaluation. So this is his baseline angiography we found on the cath lab. So basically, he has very severe RCA disease with heavily calcified all over the place. Then we decided to take care of these. So at the time, we were using 6 French guides, the hockey stick guide catheter, and then the pro-water wire was advanced distally, and we placed a microcatheter, and also extra supports, we were using the guideliner 6 French. Then we did our pre-dilation sessions with 3 millimeter semi-compliance emergency, and then we followed by lithotripsy with shockwave system 4 millimeter 4 ATM, like about 9 pulses. Then post-dilation was done with non-compliance NCU PORA at 4 millimeters. Then we decided to place on stents distally force with synergy system, 4 millimeter diameter, length was about 48, at 12 ATM, post-dilated with NCU PORA about 19 ATM. This is film. Then after that, we pay attention to the proximal area, putting another same size 4 millimeter synergy system, 28 lengths, up to 12 ATM, and then post-dilated. This time we were using a bigger balloon, 5 millimeter NCU PORA, up to 18 ATM. So it went smooth until it doesn't. And then shortly after, we noticed Ellis type 3 coronary perforation at mid-proximal area. So we tried a balloon tamponade first, where you were using semi-compliance emergency 4 millimeter size, 10 ATM, approximately 10 minutes. Then definitely that reduced the leak. However, unfortunately, the persistent extravasation was noted. And then more importantly, now patient became kind of crushed. So patient need a vasopressor, his blood pressure dropped to 90 to over 60, heart rate went up to 100. So we decided to intubate him, get another access into femoral, left femoral artery and a venous access. Then we tried to manage that perforation with the ping pong technique. So we placed that original hockey stick in place with the balloon inflated, and then use a second catheter, AL1 in this case, ampoulettes left 1, 6 French, to re-engage RCA, and then with the brief decompression of the balloon, we quickly rewire the distal artery, and then we successfully delivered covered stents with a minimal interruption in balloon tamponade. So after that, this is the procedure that we were showing. Then this is final pictures. So we don't really see any significant perforation after that. We definitely still have the coronary perforation, but patient was still tenuous. He was still requiring vasopressor, and because of that, we obtained emergent surface echocardiogram. So because of the window was really, really like limited, we don't see any significant pericardial effusions, but due to the ongoing hemodynamic instability, we did a very focused subcostal view to take a look at any like other signs of pericardial effusion. Then we found these moderate size, completely obliterating RA causing the cardiac tamponade. So here comes our challenges.
Can you please press on the play button there? There you go.
Yeah, we can move on to next slides. Yes, great. Yes, so there are major 4 challenges to be faced at the time. First of all, as we discussed earlier, there are poor acoustic window that's kind of disabling standard pericardiocentesis approach, such as like parasternal or subxiphoid. And also patient has ongoing hemodynamic instability. By the time we were using like at least 4 vasopressor. And then because of that, we talked to like a CT surgeon. The patient deemed not a great candidate for the surgery either because of that advanced age and also patient having ongoing instability. And also, even for them, it's really hard to drainage surgically either. So we had to think about some other option. What's the alternate approach? Then that's the time we talked to the interventional radiology. Then together, we decided to try transhepatic pericardiocentesis. Sorry, it's not reached. Okay, sorry. So it's conceptually similar to transhepatic gallbladder drainage. So we were assessed posterior pericardial space through the lever. As you can see, red arrow in our picture here, the needle was directed to the like posterior area with that trajectory. So, and then under fluoroscopy and then echocardiography combined guidance, we were able to avoid any significant like intrahepatic vessel involvement. And then we were using curvilinear probe instead of usual cardiac probe to visualize the access and also the deeper organ like posterior pericardial space. And once we get there, we place the microcatheter to drain the blood out of the pericardial space. So that's successfully evacuating 80 to 90 cc of blood contents out of his pericardial space, and rapidly that stabilized his hemodynamics. So shortly after, we were able to wean off all vasopressor. And then on a repeat echo, as you can see here, there are near complete resolution of that cardiac tamponade. There are maybe small size of pericardial effusion adjacent to right atrium, but there's nothing really significant. And the patient like definitely hemodynamically better. And then we did a right cardiac cath. There was no signs of cardiac tamponade anymore. So otherwise, his hospital course was not complicated. We removed the pericardial drainage catheter at post-procedure day 4, and then patients discharged to local rehab after that. So there are a few key learning points that we learned as a team. So cardiac tamponade is really, really rare from coronary artery perforations right after the CABG patient because there are literally no pericardial space. But if that happened, they present atypically with localized or loculated effusion compressing one cardiac chamber, like right atrium in our case. So high clinical suspicions, and we need to come up with better or some alternate creative approach, such as transhepatic pericardiocentesis, can be life-saving in this kind of situation that standard pericardiocentesis are not feasible. That's all I have. Thank you for your attention.
Thank you, Dr. Park. I think that the panelists had some questions. How do you ensure you're avoiding these vessels? You said while avoiding the vessels. So how do you ensure you do that?
So as I said, we were using the curvilinear probe, and also we were using the fluoroscopy. As we don't have that image saved, but he was not cardiologist. He was interventional radiologist. Actually has done this before many times to drain the gallbladder, so they feel comfortable to do this.
So that's a good point. If radiology is comfortable doing it for other indications,
Right.
it makes sense. It looked like there might have been some hepatic hematoma or something in that last view.
Yeah.
The other thing, I think the teaching point, though, is that we're always taught that post-CABG, typically does not have tamponade because the pericardium is
Right.
open, and so you oftentimes won't get circumferential effusions because it'll ultimately drain. But you can get these locular ones, which I haven't really seen, but I think you have to have a high index of suspicion. I think that's the case.
Right. Thank you.
Yeah, completely agree. Actually, this is the worst complications you can have because you can do very little percutaneously. And I think the message here is that if you have something like this, call your IR, because I don't think we are feeling comfortable going through the liver and draining all that. But this was amazing safe. Congratulations.
The other thing I'll say is we're oftentimes used to in the cath lab having hemodynamic support to bail us out. But the problem is if you just do LB support and you have tamponade of the RA, it doesn't help. You can't really put ECMO either because the RA is also compressed in ECMO. So I think you're stuck with this. I guess the patient did well enough to get this coordinated because it probably didn't happen right away. It probably took an hour to get this
Right,
coordinated.
at least an hour, yeah. All right. Thank you.
Well, thank you so much, Dr. Park. We're going to move on to our next presenter. Congratulations on your work. So the next presenter is All Roads Lead to Rome, and this is by Dr. Ahmed Elborae. And I think that we should also maybe give some grades for how exciting the title is, because there are really some fun titles.
Thank you. Good afternoon, everyone. One said all roads lead to Rome, and today you will discover one of these roads. So our patient is a 57-year-old lady, status post mitral valve replacement twice. Last one was on top of severe paravalvular leak, presenting with shortness of breath on moderate exertion and severe hemolysis necessitating repeated blood transfusion. Her echocardiography showed dilated LV internal dimension with preserved systolic function and significant anterolateral paravalvular leak exactly at 10 o'clock as shown here. After heart team discussion, the patient was opted for percutaneous closure, and usually in such location of defect, we choose to do high and posterior septal puncture. But what I am doing here, it is a coronary competition. Let's see what happened. After repeated trials of TE-guided septal puncture, we did some off-label technique, which is doing the puncture using CB12 CTO wire. But what we noticed here is the funny course of the wire, so we opted to do some sort of contrast injection, and here is what we get. Oh my God. What we see here, it took us seconds to understand what is going here. Actually, what we see here is a fistulous communication through the septum, intramurally into the aorta, then into the roof of left main, and creating a large hematoma, almost occluding the left anterior descending artery, and it finds its way or another into through fenestration into circumflex, which obesified here. So at this moment, the patient was hemodynamically stable, but I am the one who had chest pain at this moment. Surgeon was notified, and we have already a femoral access for the BVL rail procedure. So we chose a less injurious Jotkin left guiding caster to engage the left main, and relatively safe wires like cyan blue to wire both branches, LED and circumflex. Then at that moment we had important question: are these wires are distally in the true lumen? Are we within some false tracks? So our decision was to do intravascular imaging using IBUS, and what we found that we had a large intramural hematoma compressing the left main and the LED, and they were distally in the true lumen and the LED. After this, we introduced a guideliner to minimize contrast injection during positioning of stent, and the BCI was done using a 4.0 stent followed by both using a 5.0 balloon with satisfactory result. At this time, we had a discussion between us and the surgeon: should we stop? Should we refer the patient to surgery? But at this moment, the patient was hemodynamically stable, no pericardial effusion, everything is okay. So we agreed to give it another trial. At this time, we did the septal puncture with the aid of steerable Agilis sheath, and it went successfully. Then business as usual, wiring the defect, doing a rail for more support, and the closure of the defect using one AVB3 plug with satisfactory result as shown here. The patient was discharged safely after 48 hours. And my learning points for this case is imaging is progressively become the standard of care for transseptal puncture. And in some difficult cases, electrocautery or radiofrequency facilitated transseptal puncture might help, but definitely not what we did using a CV12 wire. Coronary training is essential, even in structural program, to be able to deal with potential complication. And there is our route to the coronary or to room. To imagine this, the wire took a course through the intra-atrial septum, through the roof of the aorta into the left main. And thank you from our team at Aswan Heart Center. Thank you.
It's a great case. You know, it really does highlight one of the most common errors or complications related to transseptal, which is superior. And so, you know, if you look again at the orientation of the atrial septum, if you're going to slip one way, it's going to slip superior into the root. And there have been a number, if you want to see on Twitter, angiograms from a transseptal. That's how it happens. It's actually something that is unfortunate that can happen even in these cases, but especially in this case with the previous mitral. Did they patch the atrial septum? Do you remember?
No surgical notes for this.
Yeah,
procedure.
so they might have gone right atrial, patched the atrial septum, made the septum tough for you to cross, which then caused you to slip superior into the root. So, but it's an interesting.
I have a question.
Yeah.
So what was the reason to fix the coronary here?
Oh, because his transseptal went into the root and he was actually in the aorta.
Yes, as shown in the IVAS images, we had a progressively large hematoma compressing the left main and the LED. So we had to decompress both spaces.
Yeah. It's nice that you also didn't have to fix anything on the way out when you pulled your transseptal sheath. Right.
What again?
Yes. Well, but your transseptal sheath had not caused a perforation.
Yeah, no.
That it was just a hematoma.
Yes.
So that's fortunate. Yeah. It's a great case.
Thank you.
Thank you.
Great job. Okay, next up we have Navigating the Unknown Chronic Total Occlusion of an Anomalous RCA by Cyrus Munguti.
Thank you. I'm excited to be here representing our case from the University of Kansas Medical Center. And our topic today is navigating the unknown. At the time, we didn't know it, but you guys already know that it's an anomalous coronary. So let's see how we handled it. I have no disclosures. So our patient is a 58-year-old male patient who was referred to our hospital from 3 hours away for exertional dyspnea and progressive shortness of breath. He could only walk a quarter mile on a level ground before experiencing his symptoms. We did a perfusion scan, Defect, and he had an inferior ischemia, as you can see on these films. So these are the referral angiograms that we received. As you can see, he has moderate disease on the left side in the LAD. They could not engage the right coronary, and so because of progressive symptoms and trouble engaging the right side, they decided to refer the patient to us. And again, as you can see, there were no visible septals on these films, and so we had to figure out how to access the other side. So really, our clinical challenges were how are we able to localize the RCA, and how are we going to safely cross the CTO that was there. And so we already pre-planned and decided to do a retrograde approach. We're going to go through the septal perforators, and we were able to do that using the cyan black and packed our microcatheter in the distal RCA. From there, we exchanged it for Mongo, and as you can see, as we advanced the Mongo towards the CTO, it buckled, and the image here is showing the buckling. There are a few other images that I will not show, but after this, we escalated to the Hornet. The Hornet could not go. After that, we again progressed and increased the strength of the wire. Eventually, we used a Stato 20 And the Asaro 20 made some progress, but it could not cross. The field was wrong, and so we decided to de-escalate back to the Mongo. And so when we put the Mongo, the second time, we knuckled it, and it was able to safely cross using the track formed by the Asaro 20 to the distal, to the aorta. And then from there, we were able to snare this. I think it's the next image, using a Tulip 1830, and be able to pull the guide using the new access that we have obtained. From here, we're able to pack the guide, and from that, we expanded the CTO obstruction, and we're able to take some shots. And so, as you can see, the shot we obtained here, there was diffuse disease in the RCA. And so from there, we decided to do some dilatation using balloons so that we can be able to IVIS this vessel. Note here the close proximity of the RCA ostium and the left main. So from there, we're able to balloon the proximal RCA CTO, and then we decided, because of the extensive disease, to place stents in the proximal mid and distal RCA. And then, as we are placing the stents, as I said, we did IVIS before. We placed the stents, we optimized, did another IVIS, and we're able to see our final images here. So this is our final angiogram. As you can see, was a decent flow with no flow limitations. But the story does not end there for this patient. So we were concerned this patient had a malignant cause of his right coronary. And so we wanted to do a CT scan, but because we had already exposed a lot of dye on him, we decided to plan for the CTA at a later date. We brought him back in 2 months and did this. So as you can see on this still image of the CTA that we obtained, the proximal RCA previous stented vessel still had some narrowing. And unfortunately, fortunately, the patient was actually doing very well. He had no symptoms, and so we decided to just leave it alone. The plan for this patient is, if he develops new symptoms at a later date, we are going to consider doing CABG, and especially if his LAD disease progresses, so we can have multiple vessel bypass. So the learning points here in our case is pre-procedure planning. In hindsight, we should have obtained a CTA before going in so that we can figure out where this was. But because the patient came from far and he was not willing to come and do CTs and go back, we did not obtain this earlier on. And then the second learning point is flexibility with the team about escalating to stiffer wires and de-escalating when the feeling is not right. So thank you very much. I would like to appreciate my team. Dr. Tony Spady is here, and my other colleagues at Kyeeun.
Thank you so much. That's really a nice presentation. Manos, how often are you using CT for your pre-procedural plannings in your CTO? In a case like this, would you have used it, and do you use it in all your cases?
So I'm the wrong person to ask because I do it almost 100%. Now the cases we get are usually failures or super complex cases, so it's, but this one, when you don't see a coronary artery, this is actually the perfect example. I mean, coronary anomalies are not very common, but it has happened quite often. You see that you don't see a coronary artery, it could be anomalous like in this case, or sometimes what you see is that the artery is in the right place, but it's a flash ostial occlusion, which is a completely different way to do it. You were still going to go retrograde, you were still going to do this externalization. By the way, it was a phenomenal way to put a knuckle wire instead of the stiff wires. We had the same experience. Sometimes the stiff wires get stuck, you put a polymer wire, and the polymer is more likely to go along the course of the vessel. So, extremely well done. But CT would have made this a little less stressful and more predictable.
Would your management have changed? This is working right. Would your management have changed if regardless of the path of the RCA, meaning that if it was between the aorta and the PA versus coming behind, because we know that there could be compression, and sometimes these patients do better surgically than trying to put a stent. Did you look at that? You didn't show the CT where the path was.
Oh, so the CT scan we obtained, the path was actually malignant, was behind the aorta.
Behind, right?
And so if we knew this, we would have done probably different approach.
Manos, would that have changed if you saw the CT beforehand? you have stented it?
Yeah, and again, these are cases you don't see very often, right? But I mean, then the question is, do you have a surgeon see them? If the surgeon was to operate. Now, to go single vessel bypass on the right is probably not the best thing to do anyway. So you can make an argument, if it works to stent it, then fine, you know the risk of stent thrombosis or compression is pretty high, but sometimes maybe you put a very high tensile, maybe a very strong stent like a Megatron or something, and this way you might have less chance of compression between the aorta and the pulmonary artery.
Thank you.
Okay, great job.
Strong work.
Next up, we have the inaccessible CTO, Dr. Mohammed Dabbagh.
All right, hello everybody. My name is Dabbagh. I'm from Emory. I'm an interventional critical care cardiologist, and because I'm allergic to money, I went back to CHIP training a couple of weeks ago. I want to give kudos to my partner, Nicole Chocolazzi, and the real mastermind behind this case is Dr. Wissam Jaber. So I don't have any relevant disclosures. We had a 62-year-old male who was coming to us with intractable angina. He has a history of CABG a couple years ago. He didn't have a good lima, so they did a Y vein graft to the LAD and OM, and they had a vein graft to the RCA. His ejection fraction had been all over the place, down to 30%, but immediately before this procedure was around 40%. He has CKD, creatinine around 1.5, diabetes, and AFib, and these are his medicine. He's on some good GDMT and 2 antianginals. So this is the referring shot. You can see that we have, this is a caudal shot. We're going to use a lot of images over here. So we had a CTO of the circ. Maybe there's a channel over there. You can see, obviously, the LED is a CTO as well. And over here, we have the right-sided shot. And so the RCA is also a CTO. There's a vein graft going to the RCA that is patent, but there's no septals to the LAD. And you can see this large branch over here that's filling the LAD. And that LAD is filling in retrograde the vein graft to the LAD. The ostium of that Y vein graft is also occluded and is forming a closed circuit. And because that vein graft is filling retrograde, it's going antegrade again, and it's filling the circ over here, but we didn't stay, the referring physicians stay long, so we can't see that. So, you know, before I go to the dual injections, I borrowed my daughter's iPad for 10, she only allowed me 10 minutes, but I drew this just to kind of clarify it for myself and for everyone. RCA CTO, circ CTO, LAD CTO, and the vein graft is occluded at the ostium, and the flow is going through that branch from the RCA to the LAD, retrograde to the vein graft, and then going down to the circ, and then filling retrograde as well. So this is what we were dealing with over here. We brought the patient to the lab, and this is our dual injection over here. Again, this kind of confirmed our understanding of the anatomy. RCA CTO, vein graft, again a caudal shot over here. That's the, in a second it will come, that's the LAD over here, filling the retrograde, the vein graft, ostium occluded, and down to the circ, and you can see the circ filling over here. We'll see that a couple more times. So this is our aerial caudal shot. Again, we can see that the LAD is filling through that vein graft, to the RCA, and then it's filling the vein graft retrogradely and then down to the circ again. And then in the cranial shot, you can see that a little bit more as well. And you can see that the LAD probably has also 2 occlusions over there. All right. So hopefully you all understand the anatomy. It took me a while to understand it as well. So the LAD is chronically occluded, the circ is occluded, the vein graft is flush occluded at the ostium, it's not really accessible. And so how are we going to open up the LAD and the circ, and what access are we going to use into, like what interventional collaterals are we going to use? So, you know, our plan was to, we saw that circ maybe had a channel, and so we engaged the left main and we went antegrade with a pilot 200, and luckily the pilot 200 flew forward, and this is what that looked like. We accessed the circ, we ballooned it, and then we used a SUO3 wire to go retrograde into that vein graft. This is somewhat of a cranial shot. Once we got into the vein graft, we were able to get to the ostium of that vein graft, and we took a pilot 200 and punched through the vein graft into the aorta. And once we were in the, so this is another diagram showing that we were down to the circ, back to the vein graft and into the aorta. And then we had an R350 wire that we snared into a JR4 guide over here. And then once we snared it over there, we used that as a rail to get into the ostium of the vein graft, and that gave us access to the vein graft down to the LAD. And so once we had that access, we were able to get a wire. We used a SU03 to get down to the vein graft to the LAD, and then back upwards into the LAD. And you can see that wire going into the septal branch of the LAD. And so we were able to get the wire all the way back. Now, antegrade, retrograde is a little bit relative over here, but we were able to get that wire down to the vein graft, or the limb going to the LAD, and back to retrograde into the LAD, into the distal cap of that CTO. And so, we had a pilot 200 going into that distal cap of the LAD CTO. Our challenge over here was that we were getting subintimal and we weren't able to cross true to true lumen. And so we decided to do reverse cart, but as you guys know, the challenge with the reverse cart, and I think somebody talked about it yesterday in one of the presentations, is that we don't want to extend that dissection plane into the left main, because then we'll lose the flow to the circ. And so what we did is we had a wire antegrade, and we used a couple wires retrograde, Confianza Pro 12, Gaia 3rd, and Pilot 200, not in that order. But we also put a balloon in the circ that showed us where the circ is, and we wanted to make sure that those two wires are not meeting in the left main, but in the LAD ostium, so that we don't compromise the flow or propagate the dissection into the left main. And this is our picture. I'll let it play for a little bit. It's showing you our two wires in the LAD, and that's our circ balloon over here. It's a little bit hard to see. But in some of those projections, as we're rotating the II, you can see clearly that that's a circ balloon over here, and then those wires are nowhere near the left main. And so we set up our reverse cart in that way, and we ballooned over there, and we were able to get a Gaia. Well, before I do that, that's how our picture looks like. This is my final diagram, I promise. But we have the wire into the distal LAD cap and then antegrade. We set up our reverse cart over there. And then we were able to get a Gaia 3rd retrograde into that antegrade guide extension, and then got it into the guide. Once we did that, we exchanged for an R350, and we converted the case into an antegrade case. And we stented the left main using the DKT technique that we learned from Stefan Renfret, and we had good flow in the LAD and the circ. I should say that we followed up with the patient in about a year. His EF improved, and he's doing great. So the challenge in this case, I mean, honestly, it's the anatomy. I mean, how are you going to get into that difficult anatomy? And so our understanding of that anatomy before doing the case kind of highlighted that. We did not use a coronary CT because we didn't think that we had cap ambiguity, and we understood the anatomy through dual injections. We did use, we had the other challenge was the flush occluded vein graft, and so we used our understanding of how we can rail in guides with snaring it into the guide. And then the third challenge was the reverse cart and doing it in the ostium of the LAD. And so our using of that blocking balloon in the circ helped us kind of be able to not compromise the left main. And that's pretty much it. Thank you.
I have to ask you a question, because this is phenomenal. I've never seen anything like this.
Yeah.
Just imagine you were filling the entire Y graft.
Yes.
Just imagine. And you had a little nub of the vein graft you could engage.
Correct.
And you poked through with a guide wire, and you opened it because it was very short.
Yes.
Was that tried ever?
So there was, and I probably should have showed that picture.
Shown that, because that is the logical step of this procedure.
So there was absolutely no nub, no nothing. There's a referring physician showing a angiogram of the aorta, and there's absolutely no nub. And we've done that before. I mean, a lot of difficult CTOs. Even if the vein graft is a CTO, getting a pilot 200 down that vein graft is usually pretty easy, and that's a logical step to do. But there was absolutely no indication where that ostium was other than that marker over there.
That's a key logical step of the presentation.
Yeah. Yeah.
That's why I wanted to ask Manas, would you have done the same thing exactly?
So first of all, this is ingenious, right? This is phenomenal. To Subhas's point, let's say you do open the vein graft. This vein graft is probably going to close down again. And then you may compromise the branches because you have two branches. You have one branch this way and the occlusion is right there. So you may do the graft and actually compromise and cause an acute MI on the table. So this is not, but I love the way you did it. I mean, it was extremely well planned. This is an example. You open a CTO to open another CTO. I mean, a lot of challenges that you have to overcome. It's a lot of time to understand. Like, I'm glad you saw these graphs because otherwise I don't think anyone would understand what happened. And essentially, it's very well done. Obviously, this is an amazing center. They're, you know, at the forefront of all this. This is not to be done as your first CTO PCI. But as a long-term outcome, this patient is going to be great. It's got native stents now, no dependence on a bypass. This is the best way forward. It was complex, but happy end.
The one thing I will say is we always say that the vein grafts go down, but that has to do with degeneration score. This is more aorto-osteal, which is really an extension of aortic disease, and the rest of the graft looked okay, but I get it. I do think that if you can get the natives open, it's obviously better.
Absolutely. Thank you very much.
All right, we're going to move on out of coroners into our next trajectory. The next speaker is Dr. Stephen John, and he will be speaking on trapping the thrombi in transit.
All right. It's an honor to be here. Thank you for your attention and for this time to present. I'm a cardiology fellow from UT Houston. So our patient is a 43-year-old female, previously healthy, not on any chronic medications. Over the last 6 months, she's had this gradually expanding and contracting, with menstrual cycles actually, mass in her abdomen. Now it's about the size of a soccer ball, and in the last 2 days, she developed acute onset dyspnea at rest. And when she would get up and take just a few steps, she would have significant presyncope and palpitations. Previously healthy, could walk a mile, no issues. Family history of myocardial infarction in her mother at, when she was elderly, and same with maternal grandmother. Otherwise, no history of clotting or cardiac disease in the family. Vital signs notable for normal blood pressure, but tachycardic. And so this is so I was the CCU fellow on overnight, and this is what I saw on our bedside scan in the peristernal long view, and then here looking at the peristernal short view, you see a little thrombus bouncing in and out of the right atrium into the right ventricle. I'll show a couple more pictures of the same. Well, I guess before that, we're showing the CT scan that she had at an outside hospital prior to coming in. Had submassive pulmonary embolus with significant clot burden in both the right and left pulmonary arteries. RV to LV ratio of 3:1. Elevated NT-proBNP and troponin values, suggesting right heart strain as well as the imaging findings. And so again, just looking at that thrombus bouncing in and out from the apical four-chamber view and then overseeing it in and out of the IVC as well. I didn't include images of her legs, but she had significant DVT burden on the right greater than left femoral veins as well. And so primarily because of this dynamic picture, yes, technically the blood pressure was okay, but tachycardic, very symptomatic, and in particular the worry with this thrombus, could she at any point in the night go from submassive to massive, mortality of 15%, more like to 50%. That's what prompted activating the lab overnight. And so the approach for this lady, so step one, underwent angiovac thrombectomy, and so 7 French access in the RIJ that was upsized to 26 French, and then on the left femoral side, on the venous side, 7 French access that was upsized to 17 French, and then just in case VA ECMO would be necessary, 7 French on the right femoral artery axis was secured as well prior to this procedure. The angiovac catheter was advanced from the SVC, and we were doing transthoracic echocardiography at the same time, largely targeting echocardiographic improvement of clot burden. And you can see some of the thrombus that was sucked out in our pre and post echo images. And then we turned to the lungs, and so I'll show images first on the left pulmonary artery and then on the right pulmonary artery. We used the AlphaVac device, and so we upsized that, that left femoral venous axis up to 24 French, and then used the AlphaVac catheter first on the left and then on the right, trying to suck out clot. This our endpoint primarily targeting just the fluoroscopic appearance of clot. And here on the other side as well, and trying to balance the risks of essentially just blood loss from additional suctioning of clot with trying to take out as much as we felt we safely could. Just some images of the thrombus burden that was removed from the lungs as well. I'll highlight here the right heart catheterization immediately before the procedure, before the, so I should have mentioned, after the angiovac procedure and then before the AlphaVac, that's when we did this first right heart catheterization. You can see significant pulmonary hypertension, mean pulmonary artery pressure of 34. Our PAPI getting close to 1, RV certainly, certainly struggling. You can see good immediate improvement of the mean pulmonary artery pressure down to 22. We did a subsequent right heart catheterization a few days later that I'll talk about in just another slide or two. You'll note on that one that sustained improvement in her mean pulmonary artery pressures, if anything, a little bit low filling pressures, and so we actually gave her a little bit of fluids based on that second follow-up right heart catheterization. And then the third piece I'll mention, we thought about, while we were doing so, she's underwent the angiovac and the AlphaVac overnight. Do we additionally go and try and suck out some of this femoral thrombus burden as well? The decision was made that it's middle of the night, the team's tired, but also more importantly, she still has this significant abdominal mass, and so trying to turn her over and then go through a popliteal approach to suck out some of that femoral residual clot might be more risk than benefit, and so an IVC filter was deployed rather than additional thrombectomy. Sample was sent from that abdominal mass, and as you might have expected from that history of expanding and contracting with menstrual cycles, it turned out to just be significant fibroid that hadn't been managed, but no concern for malignancy based on the tumor markers. And then, as we would expect, all the samples that we sent from what we aspirated was all thrombus. And so this is where that second right heart catheterization that I showed you came in. So then the question is what to do about this massive fibroid. Certainly a fair bit of her clot has been, as much as we could, was debulked with that concurrent angiovac and AlphaVac. But the surgeons wanted input on whether it's safe to have an open abdominal surgery where they can remove her, where they needed to remove her uterus, and also check and make sure if any other additional organs needed to be removed. And so this is where that second right heart catheterization was done with ice. It showed a good mean pulmonary artery pressure, no ongoing pulmonary hypertension, low filling pressures for which she got some fluids. And then we used ice. We chose ice rather than a transesophageal echocardiogram because we wanted to minimize sedation. Ice showed that there was a residual 0.5 by 0.6 centimeter clot, what we presume to be clot, adherent to the septal tricuspid leaflet with significant prolapse of that leaflet. The decision was made not to go after that, given that it was small, given that her hemodynamics were good, and the worry was that, okay, we go after that. If we damage the tricuspid leaflet, maybe she'll be in a worse situation. But we did leave the right heart catheter. We left a CCO swan in so that as anesthesia provided the sedation for her open abdominal procedure, they would have additional guidance on hemodynamics. And then at that time as well, at the time of the second right heart cath, again, femoral abscess was placed and ECMO was available in case VA ECMO would be needed during that procedure. So, thankfully for her, the leiomyoma was resected, uncomplicated course of that major operation. Subsequently, the IVC filter was removed. She was discharged on some Lasix and some Eliquis. So the learnings for our team, this case provided an opportunity to use many different tools to address thrombus. How we're putting it together, we're just assuming that this large, massive fibroid was leading to compression, venous stasis, and then these clots ultimately, some were in the heart, some made it all the way to the lungs, but just a chance to use a couple different tools to try and resolve this burden of significant thrombus. And this question of how much clot do you try and take off? With the right atrium, we were using echocardiographic guidance. And then with the pulmonary emboli, using angiographic guidance, but then just trying to check our work with the right heart catheterization pressures to see whether we had taken enough out. And then before undergoing additional surgery, just seeing what the status of the right heart was with the catheterization, and also using ice to evaluate for additional thrombus burden. And with that, I'd like to thank you all for your time. Open it up to any comments or questions.
Steve, great presentation. A couple questions to ask you. What was the, it's a little bit unusual because you said the RV to LV was 3-to-1. The clot burden was huge. It seemed like there's some chronicity to this, meaning that she was probably throwing clot for a long time. You did get a lot out of the left side, but the right side, there was still a lot of residual clot. What was the hemodynamics and what was the cardiac index at the time of the incident procedure?
Good question. So I'll go back to that slide with the, I'm sorry.
But that's a different presentation.
That's a different case.
Can we go back a couple slides?
Just tell us. Don't worry about it. Just tell us. Yeah, don't worry about it.
So-
You don't have to. We believe you.
Her, yeah, that's a good question. So her initial hemodynamics, cardiac index was preserved. As you saw from the numbers there, right heart was preserved, but right on the borderline, PAPI of close to 1.
Right.
That's a good question of the chronicity. I think, yeah, this mass had been slowly growing over 6 months. How long had it been that the clots had been, and then what degree of clots in the lungs was chronic, and then what degree was acute? We were certainly worried that a good portion of the pulmonary clots were acute, and we were worried for even more, right, with if that RA clot dislodges. And yeah, there likely was a component of chronic as well.
And what was because the alpha vac works very well also in clot in transit and, in general, if you can take it out of the lungs, you can take it out of the right atrium.
Sure.
So what was the decision to use 2 different technologies to do this? What was the thought process?
Yeah, and probably multiple different ways to do this. Our thought process was with the angiovac, because you have that continuous suction, thought of just there being a slightly lower chance of embolizing clot, so you have this continuous 3 to 5 liter per minute of flow, and hopefully we're sucking up clot, but even if our funnel is not directly aimed at the clot, maybe that flow will just help entrain additional little bits, but you probably could also do it with the AlphaVac as well.
And what did you do with the iliocaval clot that was already there? What did you guys do to make sure with this 26 French, just pushing those things up, you don't embolize more? You said there was clot on both sides or just one side?
So primarily on the right femoral vein, there was clot. So with the 26 French, we were coming from above. And then there's a question of, well, would you want to take that device farther down and try and suck out some of the femoral
So you did it all
clots?
from transjugular?
Yeah, so our suction with the angiovac was from sucking, it was just the return cannula.
The return cannula was in the groin? Okay.
Yes,
I got you.
exactly, and that in the left femoral vein.
All right. Thank you so much. Oh, there's a question? I'm sorry. Go ahead, Sergio.
My question was along the same lines. You had a cannula in the left femoral veins, but you had a CT that should have shown you where the compression was and what your venous access was. So I'm assuming that you had some challenges if you came from above and not by femoral, but you had one in the femoral. So I was a little confused on what the pre-procedure CT showed you, because you had a CT that showed the abdominal mass. So you should have known where the compression was and what your access points were. Because sometimes the fibroid and PE link is like, I screen all my patients for fibroids after PEs because there's such a high prevalence. And you often will have, when you put filters or you're doing any iliocaval work, you need to be worry about those compression areas.
Sure.
Yeah, that's good.
Okay, great job. Thank you.
Thank you all.
Next is total percutaneous restoration of CNS flow in a patient with Takayasu arteritis by Mustafa, Kursat, Tigen.
Thank you. I want to thank to the organizing committee to invite me here for presenting my work. And I'm coming from Turkey and from Marmara University. I will present a rare case today. The patient is a young lady who is suffering from Takayasu arteritis, and she presented with confusion and amnesia and somnolence and some type of syncope. She was under follow-up for Takayasu for 16 years, and her physical examination revealed pulseless upper extremities and carotid arteries. Also, CT angiography revealed total occlusion of brachiocephalic and left subclavian veins and subtotal occlusion of the left common carotid arteries, and really reduced antegrade flow to the central nervous system. To be short, this is the diagnostic angiography. This is the right carotis and subclavian, no filling at all. And this is the left carotis, a tiny filling, and left subclavian is also totally occluded. So the decision making for this patient was so critical because the central nervous system blood flow was really reduced. And this is the blood that is supplying the central nervous system from the left carotid artery. So rheumatology, cardiovascular surgery, neurology, and cardiology joint consultation came to a decision to stage percutaneous approach for restoration of the central nervous system flow. And there were potential risks for embolization and acute peripheral cerebral stroke. And which vessel to start first, the occluded one or the one that is in the left side? And intervention for a total carotid artery was really complex, and is there a need for that? Balloon dilatation or stent implantation after opening that vessel, because it was not a atherosclerotic lesion. Single or both carotid arteries to intervene, or medical treatment after following the intervention. These are all discussed, and we decided to open the occluded artery, because we want to preserve the one that is supplying the central nervous system. And both interventions were performed with appropriate support catheters and dedicated CTO wires, microcatheters, dual lumen catheters, and balloons with experienced CTO operators. After recanalization and ballooning, the glide wires selected for delivery of peripheral balloons and self-expanding stents. No filter devices were used, because we know that this is not atherosclerotic. This is something like a rubber, and inflammation related occlusion of the vessel, and dual antiplatelet therapy for 6 months as usual, and 6 months CT angiography follow-up plan for that patient. This is the procedure for right. We engage to the vessel, and you see that distal filling, we can see that, but the vessel occluded part is constructed with some kind of channels. So we started with a microcatheter and a polymer jacketed wire to engage to that micro channels, and after that we reached to the distal of the vessel with a gladius wire. This is a tip injection. You see that there is a bifurcation over there, and the vessel is going somewhere different, and there's an angulation. So we brought there a dual lumen catheter and engaged to the segment with a Gaia. And after that, we followed with the microcatheter up, and we had a tip injection. Tip injection demonstrated that we are in the true lumen. So after that, we started our ballooning, after changing the wire, of course. And we had that, and we delivered that part, self-expanding stent. This is the first stent, and balloon dilatation. And after that, to the ostial segment, a balloon expanding stent, and finalize the procedure. And this was the final procedure after revascularization. After that, the patient started to suffer from headache and some symptoms of acute injury. So the patient stayed in the intensive care unit for 2 days, and after that, we discharged the patient and brought back the patients to the second procedure 1 month later. This is for the left. This was pretty much easier, but the sense of being subintimal, again, with the wire, and we followed that path through a polymer jacketed wire again, and this was a gladius again. Finally, we reached distally. After tip injection and changing the wire, we ballooned that, and we also implanted a peripheral stent to that part to preserve the vessel, and this is our final angiogram, and this is our final central vessel angiogram for that patient. We discharged the patient. The patient is under follow-up, but the main issue is the anti-inflammatory therapy in these patients in terms of reducing the risk of rest stenosis. And Percutaneous intervention of central nervous system and upper extremity arteries are safe and effective in great arteries affected from Takayasu arteritis. Procedural success rate is high with dedicated CTO wires and experienced operators. Protection devices are not essential due to lesion characteristics and morphology. And restoration of the central nervous system blood flow increases the pressure and leads to hyperperfusion symptoms, and close communication with the neurology department is mandatory in such kind of patients. Thank you for your attention.
Very complicated angiographic and technical, case. I guess I have a lot of questions, but let me start by saying that, what was the reason to fix the left side if you fixed the right side? And there was seemed like the circle of Willis was intact because you see competitive flow coming. So why fix the other side if you already fixed one side and it looks good?
That was a great discussion because we know that if you just fix the right side, that's okay. It's filling from the other side. But this is something progressing. So we didn't want to lose that flow actually, because if that is total occlusion, it will be so hard for us to treat that, because we know that when you implant a stent to that segment, then it will go to be restenotic in near future. So if you lose that one, and if you lose that one, so you will lose all. So we wanted to stent that right, and after that, less complication, we wanted to stent that all, because we didn't want to lose the flow of that left also. So both of them, but not the other arteries, and they are pretty open, but these series are showing that if you stent or balloon such kind of lesions, the risk of restenosis is high, and the intervention procedure per patient is 2.6. It means that at least 2 or 3 times you will get the patient back to the cath lab and treat that with balloon dilatation or drug-coated balloons and such kind of interventions. So to have 2 stents, to have the restenosis despite such kind of inflammatory occlusion is preferred by the team.
Dr. Tigen, for this patient, I assume that the left arm flow is coming through the collateral,
Yes.
through the left vertebral.
All of them.
Yes. So, and it is quite common with Takayasu, and generally it doesn't involve the vertebral artery. It somehow spares only and involves only the proximal segments of the left subclavian and carotid. In this case, they innominate. So, like Mehdi asked the question that you open the right side, you could just treat the left subclavian proximal segment and reduce the steal of that segment.
Maybe.
Maybe not incur, because double carotid intervention, is it needed or not needed? I think you have made a decision, but it may not be needed if you can relieve the steal from unilateral symptoms.
All of them discussed. You're right, but the choice is just increasing the central nervous system blood flow. That was it.
Thank you.
Oh, thank you.
All right, thank you so much. We're going to move on to, I guess, our structural now. And our next speaker will be Dr. Sergio Mellado Flores. What is the title of your talk? I'm waiting. Waiting to
Surprise.
Okay. Great.
Thank you so much. Thank you.
So a complex, large, post-infarct ventricular septal defect, the plug and coil technique.
Yes. Well, first of all, thank you so much for giving me the opportunity to share this case with all of you. I'm Sergio. I'm one of the third-year medicine residents at UT Health San Antonio, and I'm presenting this case on behalf of the rest of the team, and especially Dr. Hamada, who was the main, the structural attending that performed this procedure. All right. So we have no disclosures. And going with the case, we have a 72-year-old female with a history of systemic lupus on chronic immunosuppressive therapy and no cardiac history. She initially presented to an outside hospital for a myocardial infarction complicated by a ventricular septal rupture and cardiogenic shock. She underwent PCI with a stent placement to the proximal RCA, and middle AD, and an intra-aortic balloon pump was placed for hemodynamic support. And then she was referred to our hospital for further evaluation by a structural team. This is a TE that was performed at our facility when she was admitted to the hospital. And you can see the ventricular septal rupture that measures about 2 centimeters in diameter and a large left to right shunt across the defect and a grossly preserved systolic function. Okay, so on admission to our hospital, we have a discussion with the rest of the heart team, a multidisciplinary approach. And at that time, she was deemed to be high risk for surgery because of her age, her hemodynamic status, and the extent of the myocardial infarction. So we decided to go with a transcatheter approach, and we planned for a transcatheter approach 1 week later to allow the tissue to scar and be less friable at the time of the procedure. So we chose a 22 millimeters post-MI VSD occluder amplatzer device for this. In the first image, we can see an LV-gram with a large left to right ventricular left to right shunt. In the second one, after we created a rail, we exposed the left ventricular disc in the LVOT. Then we pull it back, and the third image, the image T, is where we release the right ventricular part of the amplatzer device. And then we perform the talk test to confirm the device's stability. The last one is an LV-gram after we put the device, and we can see still some residual shunt there. So she initially improved. We were able to wean her off the intra-aortic balloon pump, and it was removed 2 days after the procedure. However, her clinical status, she continued to have a lot of symptoms, and it was really difficult to manage. Sometimes she would get volume overloaded and hypoxic, requiring some ICU level of care. Then we would diaries, and she would get to the hypotensive side and requiring some pressors. Because of that, we placed a CardioMEMS device. Also, her state was complicated by hemolysis, requiring multiple blood transfusions, and at some point, she was getting blood transfusions almost every other day. For that, we were expecting her to improve over time as the device endothelialized, and it created an effective seal between the blood ventricles. However, it didn't happen. She remained hospitalized in the ICU for the next 60 days, and we weren't able to stabilize her enough to downgrade or to discharge. Further evaluations at TTE, she got multiple TTEs that showed small residual per device VSD, per device left to right shunting. And after that, we performed a right heart cath that showed significant step up in the pulmonary artery with a shunt fraction of 2.0. And then we ordered a CT to evaluate the device itself. And here are the images of the CT where we can see that the device is in place and it seems like it's stable there. But we didn't see any endothelialization around the device itself, and we saw some contrast flowing from the left ventricle to the right ventricle. So what's next? So all of this pointed towards a significant shunt across the device itself. So we had a discussion with the heart team again. We discussed with surgery, and she was deemed to be still a prohibited surgical risk, mainly because they believed that she didn't have the physiological reserve to survive upon surgery. And she wasn't getting better with medical management alone. So we planned for a transcatheter approach again, and this is what we came to. So thinking about the different ideas, we came with the idea, what if we coil the device? And this is a bench testing with coiling. So we chose penumbra Robbie coils because those coils are easier to retract in case we don't like the position of the coils, and they're easier to release. So in these images, we're seeing the VSD amplatzer occluder device, and within the needle mesh, it's about 2-3 millimeters in between the mesh. So you can see how with a microcatheter we can get into the device itself. And the next image, image B, is when you compress the catheter, the polyester material gets pressed towards the middle, and it creates an effective gap at the waist of the device, which was the main target of where our coils would be. And in the last image, we can see all the coils in the appropriate position there after all of them were released. So after performing the bench testing, we took her to the cath lab, and these are the results. So we did a femoral axis, and using a biplane fluoroscopy, 12 French steerable sheet, and a mother-daughter technique, we were able to get to the device. And then once we got to the device, we used a lantern device to lantern delivered the device to slowly and in controlled fashion release the penumbra Robbie coils. And you can see eventually how in the last image it was all the waist of the device effectively filled with the penumbra Robbie coils. This is an LV-gram performed after the coils were placed. And we can see how she still has some residual shunt. However, the shunt is, the degree of the shunt is way less than it was before the procedure. After the procedure, she got better, and she was able to be discharged in a stable condition 1 week after. And she completed eventually her cardiac rehabilitation program, and she didn't have any complications the last time we saw her. So the key learnings for this is, in a patient that has a ventricular septal rupture and we're using an ambulatory device, coiling procedure isn't effective when the device failed to endothelialize and there's still some residual shunt causing some hemodynamic stability or significant hemolysis. And so special thanks to Dr. Hamada, who was a structural attending that allowed me to be here presenting this case, and who was a, yeah.
That's a really fantastic case. We really struggle with those post-MI VSDs and, you know, the sort of the not great data on it, but the only choice we have for our patients. So
Yeah.
I'll defer to Dr. Soraya.
It's a great case and great presentation and very creative solution, really, really creative. You know, it's interesting because I think you did everything right with putting the VSD device like you did. You know, these ones that are more basal, they tend to be more approachable than the ones that are more apical. But one thing that we've also started to go towards is going transseptal and going through the left atrium and placing devices from the LV side through the left atrium because it takes advantage of the curvature. If you notice on your femoral access, you know, there's a little bit of a S-turn, and pulling the device into place can be difficult, but it's a really creative solution. The one thing I wanted to ask you is, when you put the coils in, how did you make sure that the coils were in the occluder? Did you have particular imaging, or did you just see it on fluoro? How did you know?
It was just with the fluoro, yes.
Just with fluoro? Because
Yeah,
obviously if you put them in the wrong place, that's not very good either. But I think it's a really brilliant solution, because these ones that they're supposed to heal over, VSD devices, they have a different mesh than other ones. I don't think they heal the same like AVP2s or other vascular plugs. But so this persistent flow can be a problem. So
yeah, I was just going to say the other thing is that you know, surgeons want to wait a little bit, right? But I think you waited 2 months. So I think you're waiting for it to heal. But if you had waited maybe in 2 weeks and reevaluated, they could have been a surgical candidate. And sometimes they will exclude that whole area by creating a new wall and including the entire VSD on a neo-RV. That's what our surgeons have done at about 2 weeks as a possibility. So I wouldn't ignore that. But once they're in bed for 2 months, they're not a surgical candidate at that point. So.
Thank you.
Great.
Quick question. Was the patient in the ICU for 2 months?
Yes. Yeah, she was in the ICU for,
wow.
That's for 2 months.
Great. All right. Great job. Thank you.
Thank you so much.
And our last
the
talk,
coils still cost more than that 2-month ICU stay.
You think so? Last talk is by Dr. Ahmed Salama, Endgame Odyssey, When All Else Fails.
Thank you. Good morning, everyone. Ahmed Salama, MD candidate from Kyeeun University. A pleasure to be here with you. I'm going to present a case titled Endgame Odyssey, When All Else Fails. Let's see what happened. I got no disclosures. As Captain Jack Sparrow said, this is either madness or brilliance. It's remarkable how often these two traits coincide. Our case is a 47-year-old female patient, status post double valve replacement by mechanical prosthesis on top of rheumatic heart disease, mitral valve replacement in 2010, and 8 years later, she underwent aortic valve replacement. The patient complained she experienced an attack of constitutional symptoms, fever, fatigue, and malaise. Then the patient improved without medical treatment, and afterwards she presented for a regular checkup after 3 months. This is her TE. In the mid-arterial grade vessel view, we can appreciate that we got an occlusion space from 10 o'clock to 1 o'clock. The posterior part of the aortic annulus measuring 1.9 by 0.8 centimeters, and it appears that we got a communication with the aortic root. And here by plain imaging, we see that the cavity is communicating with the aortic cavity and the color reaching the whole cavity. So our clinically challenging this finally, first we thought of infective endocarditis, but inflammatory markers and serology were negative. Blood culture showed no growth and patient was asymptomatic, and when she heard she might need a surgery, she bailed out. But she came after 3 months. 3 months later, we did her follow-up TE, and that's what we found in the medial grade vessel view. We thought that's a larger pseudoaneurysm. It extends from 9 to 12 o'clock in the posterior part of the aortic annulus, measuring 3.6 by 1.6 centimeters, and extending 2.6 centimeters longitudinally into the aortic root. And here in the short axis view, it's noticeable larger than the previous time comparison with the initial images, and we got even larger communication with the aortic root. And color Doppler through both prostheses, we got well-functioning post-prosthesis, mechanical and aortic, no significant valvular or paravalvular leak. And here in the 3D reconstructed images, we can see the pseudoaneurysm and its communication with the aortic root. And from the in-phase view, we can appreciate the pseudoaneurysm from the left atrial side. Also in the bicaval view, we can appreciate that we got a small PFO with left to right shunt. So our clinically challenging, the patient had a progressively enlarging pseudoaneurysm. The patient is asymptomatic, not an active endocarditis case. This is a not great candidate for surgery. So at this time, we asked for a PET-CT to detect if there's any activity around the aortic root and also for better delineation of the pseudoaneurysm. Multidisciplinary discussion between cardiovascular surgery, structural heart interventionist, heart failure, as well as imaging and the research team. This is a CT analysis. It's also consistent with the 3E, almost the same measurements, and we got our posterior pseudoaneurysms as a clear communication with the aortic root. During discussion, out of the blue, the patient came to us again. A few days later, the patient was presented with acute pulmonary edema. In the medial 4-chamber view, we get our posterior pulsatile space. And here we thought we got our culprit. We got a significant mitral paravalvular leak. So we had to sweep it around the mitral valve to get the exact location and size and number of what we thought was paravalvular leak. In the commercial view, we thought the turbulence, but no defect. We couldn't get our paravalvular leak sites. Here in the short axis view, red and blue, true and flow consistent with our pseudoaneurysm. We got nice motions of our aortic prosthesis occluders. And what fooled us first, here we appear the pseudoaneurysm, we got a flow from the pseudoaneurysm to the aorta, and that's what caused our patient symptoms. The pseudoaneurysm compromising the aortomitral fibrosa, fistulating into the left atrium, mimicking paravalvular leak in systole. And here in the in-phase images, we can see the pseudoaneurysm, well-functioning mitral prosthesis. So that's our measurements. The pseudoaneurysm measuring 3.7 by 2.1 centimeters. It opens with 13 millimeters opening into the aorta and 4 millimeters opening into the left atrium. Average mean gradients across the mitral valve was around 40 millimeter mercury. So 2 prior surgeries, a large pseudoaneurysm, fistula into the left atrium, and double mechanical prosthesis. Surgery, percutaneous intervention, medical therapy, I wouldn't vote for that, and something else. Quoted from the patient herself, before anything, she said, "Let me die in peace before a surgeon put a scalpel on my chest." So, patient was admitted to the CCU, non-invasive respiratory support was used, and later afterward, patient was intubated. IV nitroglycerin was started as this flow acting as acute MR, and the patient was scheduled for urgent percutaneous closure of this fistula. So our challenging was we need to obliterate the flow from the pseudoaneurysm to the aorta and to the left atrium. We need to avoid hindering mechanical prosthetic motion, and we need stabilization of the deployed device. And here we go. We put arterial and venous axis through 7 femoral sheath, right femoral, and aortic root injection show the flow to the aorta and to the left atrium. Transseptal puncture was done posterior-inferiorly. And through the arterial axis, we snared the delivered wire through the venous axis. Here what we did, wire was parked in the left pulmonary vein, and otherwise were passed through the arterial axis and passed to the aorta, followed up by snaring. At this time, we thought of this pseudoaneurysm has irregular edges, irregular defect. We thought we made it a defect, and that would make it easier afterwards to close it. So we did a balloon dilatation to unify the edges of this fistula. And here we are live in action. Our wire is the pseudoaneurysm delivery sheath. We thought a muscular VSD would do the job. Muscular VSD device size 16 would do the job. And here we go, delivering the VSD to the defect. And we're about to deploy, and this time we deploy the VSD device and about to see what happened. We see we obliterated the flow from the pseudoaneurysm to the left atrium, but still we got another problem. One of the megamitral valve occluders was stuck by the mechanical VSD device, and the mitral valve is stuck in the closing position. We retrieved the device and tried multiple another times from another angles, and when we thought we did it, it's still 3D in-fast view. We got our muscular VSD nicely deployed, but mitral valve is stuck in the closing position. It has been so long. It's 90 minutes, and for a thrombus formation started to cross across the friable left atrial tissue. So we are in the end game now. What we thought at this time, we got two options. We thought of downsizing the VSD device and close the defect, the opening into the aorta, and preventing the very high pressure flow from the aorta to the left atrium, that's reducing the patient's symptoms. But at this, we thought if we are leaving the left atrial opening, it might be an idea for future endocarditis. So we thought we need to close both sides, and here what we thought, another device, AVB2 device, which is nitinol mesh, rapid embolization, endothelialization from the left atrial side. It would perfect close the job, and that's what we thought, and that's what we did already. Two devices were used to close both ends of the fistula, and here we go. We're about to deploy the two devices, and the aortic root injection we're about to deploy. And then after deployment, two devices were deployed without entrapment with the mitral prosthesis, AVB2 device size 10, and muscular VSD device size 14. And here color Doppler showing well closed, well sealed the pseudoaneurysm, no color flow through the aorta or through the left atrium. And here the devices in action, well-functioning port prosthesis, no entrapment of both occluders, the mitral or the aorta. And finally, complete sealing of the pseudoaneurysm was done without residual flow from the LVOT or to the left atrium. Followed after hospital course was the patient went into atrial fibrillation and managed by amiodarone and cardioversion. Heparin infusion and warfarin till reaching INR target of 3.5. And CVBO5 was managed positive volume expansion, packed RBCs, and finally, patient was weaned from mechanical ventilation, dobutamine, and levofed. But what about long-term follow-up of this move? After 12 months later, the patient came and we did here a follow-up TE to see the result of our actions. And here TE shows sealed previous fistula from its LVOT and left atrial end. And also we can notice what's this at the side of the previous pseudoaneurysm. It's smaller inside the previously detected posterior one. In the mid-esophageal, we got a color Doppler through the mitral prosthesis, no significant valvular or paravalvular leak, and nice motions of its occluders. And the color Doppler through the site of the previous pseudoaneurysm, no flow from the aortic or the left atrial ends. And in fast view, we got our two devices nicely deployed. And the patient herself today, she's back behind the wheel, dropping her kids off the soccer practice and savoring the little moment that makes life beautiful. She lives happily ever after. Key learning points from us, from this case: strict aseptic field measures should be applied in surgical theaters. Percutaneous intervention, reasonable alternative choice in post-infective endocarditis complex lesion in very high surgical patients. And knowing when to abort, regroup, review imaging is a key. And every patient has a story, needs a fight, and seeks every means for help, no matter how far it seems. Special thanks to Kyeeun University structure team, which I'm lucky to be one of them. And thank you all for listening. Thank you.
So brilliant presentation and very complex case. And
Thank
you know,
you.
when you're struggling, even for me, I've done a lot of these, trying to figure out exactly where you are. You know, it's a hard case.
Thank you.
So you know, choice of occluders. I mean, we tend to like the AVP2s because they're a little softer, a little easier to recapture, easier to place. They
indeed.
don't have the hemolysis concerns that VSD devices do. I mean, you still end up choosing a VS device in the end with an AVP2, right?
Yeah, both devices due to the larger opening into the aortic root, and we thought AVP wouldn't be stable enough if we close the aortic side.
Yeah, it's a great result. Congratulations.
Thank you.
Yeah.
Paul, I don't do this, so I'm going to ask you. The presence of two prosthetic valves in aortic and mitral position definitely create a scenario for careful CT planning.
Yeah.
So, I mean, of course, this presentation doesn't allow get into the details, but what would you look for, and what are some critical measures that you will look for before you embark? And second, just as an interventionalist, why do you need to balloon this? I was thinking that you
I was
don't
going to
need
ask
to
that
balloon
too.
it.
I'd rather not balloon it. Yeah, just because I think you should try to find it on echo or just using the distal end of the device to pull against it rather than balloon it, because you could make things worse. But in terms of the CT planning, it's very helpful because unless you have biplane, a lot of us have monoplane rooms, and knowing the angles to wire, you can get that off the CT. So what they do is they take the TE, find the defect that you would look on TE, find the angles on CT to turn your II to, and then you just have to position your catheters at that angle to go. It saves a lot of time. So I do like the CT for planning.
It would be a great help, but the patient would mechanically ventilated, and the fusion imaging, we don't have it, unfortunately.
Wonderful.
Thank you.
All right, so this is the moment to announce the winners. We'll have Dr. Naidu announce the winners, and please come over and we'll take your certificate and also take the picture.
Okay, great. So for the coronary winner, we have Dr. Mohammed Dabbagh for the incessant CTO, inaccessible CTO. All right, for endovascular, we have Dr. Stephen John, trapping the thrombi in transit.
And just to remind everyone, the winners become faculty next year, so even if you didn't win, I encourage you to submit your cases again. Maybe you'll be the winner next year, so congratulations.
And last but not least, for structural, Dr. Sergio Mellado Flores for the VSD coiling case.
All right, guys, so thank you all. It's been another amazing year, number 9. Next year is number 10 in Denver, August 5 to 7. Thank you all for being here. Thanks for all your support. Would love to see your cases. See you next year. Anything we can improve, please let us know. Thank you again. Safe travels.